For those who have already joined, we're just going to give it another minute or two, and then we'll get started.
Our family has always been in the cattle business. The farm was built by my grandfather in 1916, and my daughter helps me on the farm when she can. To do what I do, you have to stay in shape. So it's important, if I want to continue to farm, I need to be healthy. My health insurance had Let's Get Checked as a benefit, and so I enrolled in that. They sent me the test kit. The diabetes test that I did is very simple. We opened up the box, read the instructions, and it just went in the mail, and I had the results 3 days later. The results came online. The A1C showed that I was pre-diabetic. They called from Let's Get Checked. What she told me was that prediabetes is reversible. They suggested that I look at doing some changes in my diet and exercise, and that I talk to a health professional. I started keeping a food journal so I could see what I ate and what that would do to my blood sugar, and I found that my numbers had gone down. According to the latest test, I no longer have prediabetes. If I had not taken the test, I probably would have ended up developing diabetes symptoms. I'm very thankful that I caught it when I did. I think it's something that everyone should know because there really isn't much to these tests, and the results from them are very valuable. It gives you the opportunity to make some changes and extend your life and be healthier and happier.
Hello, everyone, and thank you for joining the team at Let's Get Checked for our conversation today on the Rural Health Transformation Program. As we're getting started, just a couple of housekeeping items. We do have all lines muted during the meeting. However, there is a Q&A box at the bottom of your screen, and we encourage you to add as many questions as we're going. We do have time saved at the end to answer questions. And again, we want to try and make this as interactive as possible, so we would love to hear from the attendees who are listening in. Lastly, we are recording this meeting, and we will make the recording available to everyone in a link after we're finished today. So just quick overview, based on our registration list, we have a wide range of attendees that have joined the call today. We have every representatives from over 20 different states who are joining us. We also had attendees sign in from various different provider organizations across the state and other groups that I'll represent, that I'll categorize as vendors. So other people that maybe may also be looking to participate in rural health transformation funding activities. So as we're getting started, just wanted to introduce our panelists for today. I'll start with myself. My name is Laura Hoffman, and I work at Let's Get Checked, and I support our business development activities for our public health and our health plan business. We also have Lindsay Jacob with us. Lindsay oversees our client support team, and she has extensive experience in kind of designing and structuring these programs. And then we also are joined by Michael Rummel. Michael, it's great to have him here. He actually leads our lab out in Monrovia, California. He is a long-standing tenured member at Let's Get Check and talk a lot about the history of what we do and how we've developed our test. He has extensive background and expertise in the development of self-collected clinical assays, which is obviously critical to our work. And his background in mass spectrometry specialist is invaluable in leading and developing our programs. So for those of you who aren't familiar with us, just a little bit about what we're going to cover today, and then we'll talk a little bit about Let's Get Checked. So again, we are just going to talk high level about rural healthcare, what we're seeing, give you obviously some numbers, a quick introduction and overview of who Let's Get Checked is and what we do. Michael's going to talk about our state-of-the-art laboratory and really with a heavy focus on the types of testing that we do and how that's applicable to rural populations. And then Lindsay is going to talk a little bit about some of the examples of customers that we've worked with, as well as some of our best practices. And then again, as I said, we are going to leave as much time as possible at the end for questions and answers. So please feel free to put in as many questions as you would like. So, a quick overview just on who Let's Get Checked is. Let's Get Checked, we're a leading at-home diagnostic platform. We combine not only screening services, but also telemedicine programs to really deliver best-in-class healthcare at home. A heavy focus of all of our programs that you're going to hear about today is really at home or in community, but really making everything as local as possible for our users. Today we have over 100 diagnostic tests, and they really span they have a large span, including wellness solutions, preventative healthcare screenings, chronic condition management, women, both collections of tests for both women and men's health, sexual health tests, and then again, as I said, we do also offer full telehealth services. Throughout our 10-year history, we've completed over 10 million tests. And again, that's all focused on in-home and/or community-based programs. And we've had more than 7 million clinical interactions across our various programs that we offer. One of the things that I love about our company is originally a decade ago, we actually started as a consumer health company. So we were really running more direct to consumer programs. I think that experience and using that as kind of the base for which we built the company, again, focuses heavily on everything we do is meant to say, how can we make these programs and products as usable as possible for the average person? These are not necessarily meant to be only used within clinical settings, but it's really to say for the consumers that we've always supported, we've used them almost as our testing ground to say what works and what doesn't, and get their feedback in all of our development work. Today, we do continue to operate a direct-to-consumer program, but I would say the majority of our business has really evolved over the years where we have a very large health plan business, predominantly focused on gap and care closing for HEDIS programs as well as STAR programs. We work with a large amount of provider organizations who are looking to offer additional services to their members that potentially can't occur either in an office or members that need assistance in providing and screening within their home because that's just easier for them. And then we also have a very large public health footprint. So we've been working with a variety of different states, counties, municipalities for many, many years. So again, really have a wide range of customers that we support today. And really, when we're starting to talk about this, I think you'll hear a little bit more about just the various different use cases and how someone who has an interest in doing at-home screenings and telehealth programs, all of the different ways that becomes applicable in different verticals. Let's Get Checked. Our mission is really to empower people to live longer, happier lives. And we aim to achieve this by empowering individuals to manage healthcare from home across the full life cycle as care. So, as much as that can possibly done within the home, those are the types of programs that our company is supporting. So, now moving on to kind of why we're all here today. Obviously, I think we've all been talking about the healthcare crisis for more than a decade in the United States. I would say anyone that has worked within the system, whether it's in the health plan system, in a hospital system, provider, outpatient services, can clearly see that there are just some glaring problems that we are all challenging with. And then I would think also, just anyone that's been a patient in the healthcare system and has had a need to receive treatment from multiple providers in a hospital stay, whatever their scenario has been, I think can also see that it's not necessarily an ideal patient-friendly system. At the macro level, the United States spends more money on medical care than any other wealthy nation, yet we have the worst outcomes. So obviously, we experience lower life expectancies. We have much higher rates of preventable deaths, whether it's maternity, infant, or treatable conditions. And the American population just has a very high and greater burden of chronic disease illness. Broken system, then, when we think about that system that's impacting the entire United States, and then we take a look at how that actually impacts rural communities, I think you see the impact is just significantly greater. You could kind of pick your number. There are so many different statistics out there, but if you think that approximately 60 million Americans live in rural areas and nearly 80% of them are considered medically underserved. One of the comments that I always find so interesting, you have your zip code is a greater predictor of your overall health than your actual inherited genetics. So again, really depending on where you live and the types of resources that are available to you, it can have such a significant impact on your health. And unfortunately, it typically has a negative impact on your health. Rural healthcare, we know that there are just certain things that are significantly making that situation much more difficult. Obviously, the workforce and access issues. So that's probably one of the number one challenges is there's just a lack of access, which really ties back to the workforce. We see provider shortages in many areas. There are recruitment difficulties. We're seeing more and more hospitals close, which we'll talk a little bit about more in a few minutes. Hospitals, we've been telling them for so long, kind of do more with less. Same thing with provider organizations. They tend to have less technology. They haven't been able to keep up with all the different technological advances, so that creates significant challenges in rural communities. Broadband gaps, even when there are additional resources available, you've got to have that stable broadband, and not all places do. We know the financial pressures that rural practitioners are under, and that's going to be through a couple of different, the razor thin margins that a lot of rural hospitals operate under. And I would say rural providers are in the same situation. They also are very challenged with the payer mix that they have. So more likely, greater likelihood that rural populations are going to be on Medicaid or be underinsured or uninsured completely. And then I would say with obviously some of the changes that are going on nationally with Medicaid eligibility, as well as ACA funding and supplements, I expect that that's going to go significantly higher within the underinsured and uninsured population. So that's kind of a growing issue with that tougher payer mix where they're just receiving lower rates of reimbursement. Population demographics, very challenging. We've seen aging population. There's more likely to be aging population that's existing within the rural communities, and we're also more likely to see the lower socioeconomic factors. So patients that don't have the same type of income levels, don't have the same type of disposable income levels, and therefore they're going to be more challenged in what they're able to afford for their health care. Rural Health Transformation Program really is trying to provide an opportunity to address these issues. So I would certainly never say that the amount of money that's being offered to each state, even if you total it up nationally, is enough to alter is enough to dramatically change what's happening in rural America. Obviously, there are significant amounts of cuts that have happened through multiple different bills that are going to have some long-lasting impacts. However, this program does give an opportunity for each state to kind of look at what their situation is and try and come up with innovative ideas. One of the things that I really like about this, and I give CMS a lot of credit for it, is this program really allows each state to look at their communities as their own communities and state. This is not a federal program that is dictating in detail all the different services that it's going to cover. This is really giving states the opportunities to be creative and look at their own local healthcare systems and decide what's needed. And that can be varied based on a county by county basis. But again, it gives the states kind of the opportunity. Now, to some extent, I do think that that's because all of these different regulations, when you think about the announcement, the application, the CMS review process, now the announcement of funding, and that the funds are already available. Obviously, that is a very, very tight time frame that everyone's trying to operate under. So that may be the reason for some of the flexibility that we're seeing from CMS in these programs. But I do think that one of the things, again, that I truly makes me more interested in this program than some of the others is that there is such a level of flexibility that's being given to the states. So now, kind of also the timing that this is happening. For those of us that closely follow CMS, there are multiple different programs that they're putting out, whether it's the access models, again, lots of different things to really say what else can we do and how can we potentially look at healthcare differently. I think obviously the rise of the healthcare, the consumer as a part of healthcare. We know that we have a very different healthcare consumer that's out there. They expect very different things. They expect healthcare to work just as other parts of the economy works. And today just doesn't necessarily work that way, but they are certainly driving and pushing towards that. Um, Pandemic certainly moved things along very quickly, but I also just think like the rise of Dr. Google and all the different ways that consumers, the advertising of prescriptions directly to patients, all of those things are again really creating a consumer that is one, much more educated about their circumstances, or at least have the ability to be more educated about their circumstances, and also those that are seeking additional options for care. Currently, what we see about 74% of the people after 74% of all Americans after the pandemic are really saying, I am more open to completing access to completing healthcare in my home, whether it was those COVID tests or the force that we all had to start using telehealth during the pandemic. Again, that shift has started and it's continued, and I think it's just going to continue over the years. So now that the state level applications are done, the funding processes are in. For those of you, again, who have been reading what various states are doing, it's wonderful to see the variety of the state focuses that we're seeing. I think there are certainly a couple of key strategies and themes that we're seeing across the board. So, obviously, workforce development and stabilization is critical. How can you bring in more people? How can you grow your own clinical community and practicing community? Technology and digital infrastructure is a significant area where states are saying they want to allocate funding. Maternal health, definitely one of the bigger ones, maternal health, and then also behavioral health. And I'll split behavioral health both within mental health treatment, critical and crisis intervention for mental health treatment, as well as substance use disorders and kind of the opioid epidemic. Those are kind of consistent themes that we're seeing. Chronic disease prevention and management, a lot that are starting even with food as medicine education campaigns. How can we do more activity? How can we do more activity for children up until older adult ages? But really that how can we limit the impact? How can we prevent and or limit the impact of chronic conditions? And then preventative care. How can we do more for preventative care? America across the country is not doing a great job with their preventative care, but that's seen even to a greater extent within rural populations. So, what can we really do to address preventative care? And then, obviously, mobile EMS. How do we get more critical access? How do we do more with hospitals to sustain and make sure that we do have enough hospitals within rural communities, that we have enough specialists? So while Let's Get Checked, we're certainly not able to tackle all of those different critical elements of what is going on within rural healthcare. There are a handful of those that we really can assist with. So whether we think of our programs as a technology-based solution, a telehealth-based solution, in-home care, we can hit many of the different objectives within the Rural Health Transformation Program. But one of the key ones is obviously how can we do more with preventative healthcare? How can we do more with chronic condition management? And how can we do more in a very unique setting where we want to be able to increase the access that patients have all across their rural communities, but yet we don't want to step in and disenfranchise those local providers. So what can Let's Get Checked do to really work with the local provider community to make sure, one, we're meeting the needs of residents in a timely manner, but then also working with them to really try and connect them back into any available resources that are within their geographies. Now, I would like to transition and invite Michael Remmel, again, the director of our labs out in Monrovia, California, to provide an overview of Let's Get Checked and our testing solutions.
I appreciate that, Laura, and thanks for inviting me to speak today to the group assembled. Yeah, as Laura mentioned, like we are uniquely suited to try and help augment areas of healthcare that have fallen short. It's precisely why we started the company, in 2015, was to be an alternative way to provide healthcare, particularly around preventative services and preventative screening. And philosophically, since we've started the company again over a decade ago, our philosophy has been we try and own every piece of the process or piece of the supply chain, if you will. And that includes, we do our own manufacturing, our own kit distribution. We have our own laboratory, which is what I'm going to talk to you about, as well as our clinical support services on the end, which is what Lindsay's going to get into as well. Um, our lab here in Monrovia, so if you don't know where Monrovia is, it's in the greater LA area. We built this from the ground up. So it's a 35,000 square foot facility. It's CLIA certified and CAP accredited. So CLIA is the federal regulatory institution that governs laboratory medicine if you're releasing clinical results. And CAP, for those that aren't familiar, is kind of the gold standard accreditation body. So what CAP means is we essentially have thousands of checklist requirements and that range from different quality metrics to compliance and governance in the lab that we have to hit. And we're proud to say we've had an incredible track record on this. We've again built a lab that is meant for self-collected or remote collected specimens that aren't always in the conventional blood tubes or conventional specimens that would be normal to a phlebotomy or venipuncture draw. So what does that mean? It's hard to just plug and play into existing laboratory infrastructure. So you need to build solutions around that where you can test, large swaths of the population and be able to do that efficiently. So what you see running on loop here is one of the investments we've made in the lab. This is a state-of-the-art automation system that was custom developed to handle what you see there. Mostly on the line are these microvets that are smaller blood collection containers as well as different swabs and other collection devices. These all run through this track system that not only centrifuge the sample, also process the blood into serum and plasma. There's a decapper, there's an aliquoter, and there's an output sorter that kind of plugs and plays then into existing lab equipment that most hospitals or independent laboratories would have. So it's a 3-year project, multi-million dollar expenditure, but you can kind of see this is what we do. This is what we're serious about doing, and we built a lab to support the whole operation. Having our own infrastructure also helps us with other things we can do to ensure quality and ensure success out in the collection in a layperson's hands. So we have our own clinical studies team with an IRB approved study that's ongoing that allows us to essentially develop instructions for use that are actually work. And we've learned a lot over the years and apply that today. That means we increase the chances of getting a sample back successfully. We'd be able to give that result out, and somebody can potentially get, care that they desperately need. And it's a call to action to get them into, again, more the traditional means of delivering healthcare. We're compliant with all departments of health for reportable diseases, so we have the infrastructure to support that as well. So any reportable disease conditions, anything from STDs to other infectious diseases, we have the ability to report directly to the state departments of health as well. Next slide, please. So a little bit more about us in the lab and again, philosophically, how we operate. We feel like we've been the standard bearer. Again, we've been doing this for a lot of years. We've really take it as a great matter of importance to do this properly. And I think, the pandemic showed that, if done properly, it can have a pretty enormous impact on the ability to deliver healthcare to the home and particularly people's ability to self-collect specimens. Again, but that has to, it's the old saying, garbage in, garbage out. Like if you don't do the work up front and validate properly, you run the risk of, patient safety issues, you name it. So we are very well versed in this area. It's more than just a typical lab validation that you would see at an independent lab, run-of-the-mill independent lab or hospital. We look at things that could affect samples, that are more unique to a self-collected specimen. So this would include multiple sampling site validations. So since you're not taking blood from the arm via venipuncture, we need to look at, how does capillary blood perform, right? Versus a venipuncture. We're shipping, specimens all across the country, sometimes from remote areas. This is kind of the subject of this talk. And so we have to look at stability, right? Does that sample hold up under, extreme temperature conditions? Does it hold up in the heat of summer? Does it hold up in the cold of winter? We look at all those things before we would ever release a result or ever release a test for, testing on patients. Those are just a few aspects amongst a very big laundry list of other experiments and aspects that we run before we, again, issue a test for clinical sampling. We're we're big believers in putting our work out there. So these are just a couple examples. There's many more. We will provide the links to these after in a post webinar follow-up. But 2 call outs here, just as examples, we looked at as part of our research on HPV testing, so primary screen cervical cancer screening, utilizing HPV as a marker. We looked at, what can a patient self-collect a vaginal specimen and can we get the same clinical efficacy as a cervical swab collected from a provider? We did this study with NIH and Kaiser, and the research would suggest, yes, that is possible. And we've seen this, for a number of years in Europe. It's becoming more of a first pass screening mechanism in the US slowly and is augmenting pap smears now. So this is an important aspect of, cervical cancer screening that's been deployed, again, elsewhere in Europe. We've looked at it here. We've successfully proven that, people can successfully collect a self-collected vaginal swab and get similar results, clinically, accurate results. As well as looking at, again, we have to look at stability in this case. So 28-day stability on a dry swab, we've proven that we can achieve that. Another example, In the Journal of Clinical Microbiology, we looked at extragenital swabs. So for gonorrhea chlamydia test, vaginal swabs and urine are a great mechanism for many people, but depending on, the nature of sex you have, you may need a different swab type. So it might need to be an anal swab or an oral swab. So we looked at those and, what could potentially go wrong with those other swab sites, right? If you're putting a specimen in the oral passages, can food cause an issue? Can alcohol cause an issue? Other, surfaces, can creams, and other things contaminate the samples? Those are some of the, aspects of the test and validation process that we sought to look at. And again, we can offer, as part of this, we can offer a multi-site gonorrhea chlamydia test. And then probably one of our marquee accomplishments was getting a de novo through the FDA for gonorrhea and chlamydia testing. So this was an at-home label that basically, validated all of our testing process from, kit design, the instructions for use, the lab testing, and the back-end clinical support. And this came out a few years ago. I have to give a lot of credit to the FDA. They were super collaborative in this process. We were able to, develop essentially a roadmap on, again, what are the things that are unique about this modality, and how do we ensure, we're not doing any patient harm? Well, this was a roadmap, again, co-developed with the FDA, and we were able to achieve this a few years ago, and it's a really important landmark achievement in the area of self-collections. So thank you guys very much.
Thank you, Michael. One of the points that I just wanted to highlight, I heard you say 28 days, but I wanted to get a couple of more ideas from you. Obviously, the majority of folks that we're specifically talking about rural populations. We understand that rural populations are going to sometimes be challenged with UPS turnaround times. So I wanted to ask you to just talk a little bit about some of the types of tests or things that you would recommend specifically for a rural population where you knew that you would have the additional benefit of longer stability of the kit that was being sent out to someone, or kind of the stability of the sample that's coming back into us, where we were sure that even dealing within rural populations, there was going to be sufficient time there.
Yeah, it's a great question, Laura. I mean, not everything can be, has 28-day stability, right? So it's a really important question to ask. And we would obviously tailor fit this, and we would have these consultative conversations with folks that are interested in what we could provide. But, off the cuff, like a couple of options that are good options that have a huge clinical value that can be done in a rural population would be a colon cancer screening test. So this would just require a small amount of fecal specimen. It's not the most glamorous collection, but it's important, and it's a very easy, collection to be able to administer in a self-collection scenario. And we basically get this test back. It detects whether there's blood in, stool, and we, again, can refer a patient then for follow-up, potential colonoscopy or other back to a GI or somebody who can help, further work up that patient. It's a very simple test with huge impact and has, long enough stability times that it can be easily done in a rural population. Another example would be like as the video off the top started, where the farmer from Iowa used one of our diabetic check tests. So this would be a hemoglobin A1C measure. We've got multimodal validations on this, so both wet blood as well as a dried blood spot option for when you do need a little bit longer stability, and that's the only option that would work. We would recommend something like that, and you can measure and screen hemoglobin A1C measures for potential either pre-diabetics or diabetics who are already diagnosed and you need to monitor that population. That's another option for that test. So,
Great. Thank you, Michael. It's
mhm.
very helpful. Now I want to turn it over to Lindsay. Lindsay has a long tenure with Let's Get Checked and has really been the architect of many of the different types of unique programs that we've deployed within the community. Because I think, it's super critical. So yes, the tests are wonderful, but if nobody's going to be using them, then obviously that's the key challenge with any program that we do. It doesn't matter how innovative, comprehensive, easy to use, or expensive a program is, if it's not being leveraged or it's not being properly communicated within the population of residents or patients, it's just going to be a fail. So one of the things that Let's Get Checked really has a tremendous focus on is really how do we communicate programs to patients? How do we communicate the availability, again, direct to patient? How do we work with local provider communities to, one, communicate the availability to them so that they're also aware that there are additional options for the patients that they see? And then also, how do we work with various other different community programs? So if a Department of Health is doing live events, if a Department of Health has in-home community workers, how do we really get our kits into their hands to ensure that they're also able to expand what they're able to offer to patients, again, directly in their home? So, Lindsay, do you want to give us a couple of examples of things that you've seen?
Sure, absolutely. Thank you so much, Laura and Michael, and hello to everyone out there. And I think Allison, thank you. Next slide. At Let's Get Checked, we're focused on both the patient and partner experience, and from that offer a multimodal delivery approach for testing. We have the flexibility to support different methods of delivery to ensure that the test is provided and received at the optimal location, and we can support more than one delivery option for your initiative. So looking here at the slide, a delivery option that we use extensively is sending test kits directly to patients. This supports accessibility to at-home testing for your rural residents with that at-home delivery, which can complement a telephonic program. We've also partnered with provider centers and health centers, like Laura had mentioned, to deliver test kits where the sample can be collected either on site or collected by the resident at a different or preferred location, like their home. That warm handoff of the test kit with patients has been an effective part of some of our partners' workflows, as it helps to build upon the relationship with your residents. An additional workflow that we have experience with is the collaboration with in-home clinical partners, where Let's Get Checked provides the test kits to be used during your in-home appointments with residents. As an extension of your existing workflow, this can help to optimize the at-home visit with a clinician-assisted sample collection process. Another option, community events are ways that we support access to at-home testing on a larger scale. With the availability of tests at local events, this can help reach an additional proportion of your residents, increasing that overall awareness to the testing availability. And all of our options of delivery at Let's Get Checked and the Let's Get Checked test kits are built upon our goal of providing access to care where and kind of how it works best for your population. So from at-home delivery to in-person appointments and on-site events. From the delivery of test kits through the result process, our focus really is to provide that streamlined experience grounded in operational efficiency and data sharing. And then sort of how we do this is what we'll talk about next, and driving that awareness. Driving awareness on the availability of the testing options to both providers and patients is a key part in kicking off the program. We focus the engagement strategy at the point of awareness of the availability of the testing, as Laura had also previously mentioned, and then through the sample collection process, like Michael had mentioned, and then through the result delivery process for all stakeholders involved. So if we look at the provider lens, depending on how tests will be provided to the population, we've developed materials that support in-person appointments and events, and really equip the provider teams with important information to share with the resident population on the testing process. And then that result information is always shared back with the providers to kind of close that loop of information. To help support our partners in their internal onboarding and training process, we provide training documentation and tips for sample collection. This information has been used for staff training in existing partnerships that I've worked with, specifically here at Let's Get Checked, and includes objection handling and just overall general awareness of the partnership. So from frequently asked questions to how patients can contact Let's Get Checked, we look to provide supporting information kind of covering all aspects of the program and testing process. And then when we look at the resident population, for that optimal reach with providing awareness to the residents, we utilize a multi-channel communication approach, also starting with kind of awareness and education of the availability of testing. This can be done through websites, social media sites and advertising, physical displays like billboards, flyers, signage, really to help promote getting the word out to your communities. And then with all campaigns, we'll evaluate the effectiveness and can modify and modify the messaging, modify the approach based on the receptivity of the population and the participation. So kind of once we get to the point of activation and for tests that get into the hands of the patient, we deliver reminder messages through multiple methods of outreach that reinforce the call to action for the resident, which is to return that sample, right? So to collect the sample and return it. Like Michael had mentioned, in each test kit, there are instructions for use that provide that step-by-step detail on how to collect and return the sample. An additional sort of option for education is sample collection videos that are included on the Let's Get Checked website. And that provides kind of that visual step-by-step process, helping to show the ease of use of the Let's Get Checked tests. And then we also provide telephonic support through our customer care team. So they can assist with questions around sample collection and triage clinical questions to our clinical team. So really from that point of awareness to activation and then through education and support on both the provider, our partner, and kind of the resident patient side, we work to deliver, a complete and robust engagement and participation strategy. And ideally, at the next kind of step in the process is sharing the data back with you. So we do have some different options for accessing results and providing that data back to you, really to ensure test results are shared with that goal of continuity of care and ensuring providers are notified, especially in the case when follow-up care is needed. This kind of example here is Halo Insights, and that's on the Let's Get Checked reporting portal, and providing real-time data at the program and the patient level. So you sort of get different cuts of the data and different levels of access across your organization as needed and as applicable. The portal does provide kind of real-time insight into the program outcomes, following kind of the progress and the trajectory of the test kit from the ordering through the results activity. So you can follow kind of each step of the process there. And then understanding there are specific reporting requirements around providing result data at the county and zip code level, and whether there are different kind of categories that we need to look at. We can configure the program to segment out the result data in that way. So our reporting capabilities are also flexible, and we can work with you to align on those requirements to deliver the requested data back to you. Also, from an integrated approach, we have many partnerships where API configuration allows for that real-time receipt and delivery of key information like order and results data, so that transfer back and forth. And our health information exchange connectivity capabilities are also another way Let's Get Checked ensures actionable data is delivered and shared in a timely manner and seamlessly back to you. So another way, again, from the result delivery perspective, is the patient experience. So patients have access, or the residents have access to their results through Let's Get Checked and through the account that they set up, and also through lab letters. We have lab result letters if that's selected as part of the program offering. If primary care information is shared, we deliver results to the identified provider, again, to provide all the information to the appropriate parties. Like Michael mentioned, when a result is reportable, we'll send those results to the appropriate state agencies with the required information. And, our main goal is making sure that that actionable data is provided to you in a real-time manner, in the most accessible way possible, and meeting the requirements of your program. So again, understanding there might be different needs, we can absolutely focus and set up programs based and report out based on your requirements. So,
Thank you, Lindsay.
sure.
Thank you, Lindsay. That was certainly helpful. And just one of the things while you were talking, that to me for the states that are on the call today, is that kind of activation and building public awareness, and how that's actually going to be achieved. Whether the states are going to be looking to do one consolidated campaign where they're updating providers, hospitals, health systems, and residents about all the new programs that could potentially be made available to them, or they're going to expect that each of their grant recipients are doing that for themselves. I think that's really such a critical point to say. There are so many programs out there that are wonderful, but if you're not getting the word out, then the programs are not going to be successful. So really trying to think through that as they're looking at different programs. Again, potential for the states to be running that type of communication to drive the activation, or to actually ask each of the vendors what their plan is and what their strategy is to really drive that activation. So I know Lindsay touched on this briefly just with some of the different types of written communications that we do, but I think it's a critical topic for us to make sure that we're covering. Really, what do we do about abnormal results? So the hope is that everyone is getting their preventative screenings or their chronic condition management, or they're receiving kits from us. And that all the results that we give them back is everything is fine, and we'll just repeat it in a year or repeat it at whatever the preventative guidance suggests. But unfortunately, that's not the situation. And the reality of what we deal with within our testing population, again, it varies based on the type of test, but we see about a 5 to 15% abnormal positive test results for patients. We are typically the ordering provider of record for these tests that are being done. So that really gives us the inherited responsibility to say, how are we actually going to it gives them that inherent responsibility of saying, how are we actually going to communicate those results back? And how do we take that responsibility, and how do we actually engage in that process? So again, critical importance that any test that we're ordering, we are typically saying, best practice recommendation, a test is completed. We always want to be issuing that information to a member in the mail. We also want to be notifying their provider, PCP, GYN, whoever they've identified as their connection in the community. We also want to be notifying them of any result, just the fact that a result was taken. Hopefully the result was normal, and they can just have that as part of their record. And then when a patient does receive an abnormal result, we do have a clinical team. Our clinical team is making outreach to those patients telephonically. We do the telephonic outreach. We do up to 3 attempts before we push out a result within the portal, because members can also access their health information via our portal. But again, those 3 calls that are going out to the patient to actually talk to them about their result. Key things that are happening in that call. First thing is education. It's explaining to the patient again the type of test that was done, what their result was, what that means, and really working with them to talk about what are their potential next steps. That next step could potentially be, do you want to speak to telehealth? We have telehealth providers that are available, if that's really appropriate based on the type of testing that was done. Or is it the type of situation where we say, a patient, you're really going to need to go in? Michael brought up FIT testing earlier. So colorectal cancer screening. If somebody has an abnormal FIT result, really, we can certainly have them talk to telehealth. However, the most appropriate thing is really to get that patient into a GI doctor and have a colonoscopy. So our clinical team really takes the responsibility to say, how can we support you in that process? And really take on that care coordination piece. Heavy focus of a lot of our populations are really serving vulnerable populations. For one reason or another, the patient hasn't gone through some of the more traditional means of care, so they're now doing at-home testing programs. There's tending to be, whether it's an economic issue, transportation issue, mobility issue, whatever the scenario is. But for us to really work with that person to say, making sure they understand what the test result was, making sure they understand what the next step is, and then really going to the effort of helping them coordinate what's a low cost option, what are free options that are potentially available, but understanding all the information and resources that are available within their community. I mentioned briefly telehealth. We do currently provide telehealth services for patients. Different scenarios that I like to give where it's very applicable. So if we talk about STD testing, somebody comes back with a positive infectious disease. How can we actually take that person who got the at-home test, did the at-home screening? We now have them on the phone. We've given them all the education. Recommendation is going to be for you to be on some sort of an antibiotic and or oral treatment. We can connect that person right to telehealth services. We have telehealth services that are available to operate all across the country, and they obviously can do e-prescriptions for the patient. So if it's appropriate, they're going to take the history, they're going to do conversations with the patient, and when and where it's appropriate, they can actually prescribe medication and really just close that entire care need where again, referrals will be made for continued care, but they're able to do that. Another one where we see a lot of activity is cholesterol testing. So someone has cholesterol testing, cholesterol comes back very high. Our recommendation with clinical education is going to be to encourage that patient to see a cardiologist, see their PCP, see some sort of follow-up. If that's now a patient who's either uninsured, underinsured, or lives in a rural area where the wait time to see a cardiologist is 6 months, well, if it's appropriate, our telehealth services can put them on a statin for now and really be that stopgap measure to provide them with the support that they need, initiate the first round of treatment until they're in a position where they're going to be able to see a practitioner face to face. So I think we are now really coming to the end of the prepared content that we have. Please start with your questions and answers. We certainly want to get as much as we can in there so that we can respond directly to you. A couple of thoughts just as you're putting those in. Really, one of the things, again, as I said, CMS, I think this is a really interesting program where they're giving so much flexibility, is really kind of a quote that I saw from Secretary Kennedy that, rural healthcare deserves a system that's actually built for rural reality and not just to take the urban and suburban healthcare systems and put more of that into rural areas. But it's really trying to figure out how do we work through that rural reality that patients really are facing and living every day. And again, just the ability for the states to go in county by county, area by area to really try and design what does that population need and what can we deliver to that population that would be something different and unique than what's been done before. Since about the August timeframe, we have had the opportunity to communicate with multiple different states. We've participated in several different RFPs, RFI activities. A lot of the different states just had public open comment periods. So really kind of seeing all of the different ideas that have come through that process. I think it's just wonderful, and I really hope that the states are now at least empowered to be in a position where they can do things that are a little bit outside the box and do things a little bit different than what they've done before because they have this additional funding and they have this additional mandate to really say, let's look at it differently and figure out how we're going to really solve for the rural reality of what healthcare is today. So now, as we're looking into the question and answer period.
I saw one incoming, Laura, that I can take.
Okay,
So,
wonderful.
question came in. This is an average person able to actually complete their own blood sample? It's a great question. As I was saying off the top of my lab slides, we have this clinical trials group that we do basically usability studies and refine IFUs. We also have real world data, and we monitor these things as QA activities like why are samples being rejected, and try and modify instructions and support, and we have videos out there, a lot of tools. And also when we're doing large scale programs, we work with if there's nurses going into the homes or any, we help do the training in that case as well. So like, is an average person actually able to complete their own blood sample? The answer is yes. It's especially if they've done it before and as they work with us, year over year, it becomes easier and easier. And it's not like we have perfect slate and every sample comes in perfect. Absolutely not. But we've taken a lot of learnings over the years and give instructions that are easy to follow, even for, patients that may have literacy issues, trying to use infographics and things that just make collections more straightforward.
Okay. Let's see. I'll jump in here on another one. How do you fit into the larger rural health transformation program? Yeah, so that's an interesting one. I mean, I think as I said in the opening, I don't think that a company like ours can be a solution across the board for everything. There are so many critical areas that need to be addressed, and just the funding across the board to really target very different pieces, and components. I think that our program, though, the types of things that we're able to do can address a couple of needs. One is immediate impact. As I said, we currently operate at a very large scale in all states today. So we really have the ability to do immediate impact type of work. So in the very short term, we can deploy a program. Usually takes us between 30 and 60 days to get a program up and running. So I think that that definitely is a place where we can fit. I think another place where we're a very good fit is just, again, you've got populations that just don't have enough access. So, what type of program can you start to design where rural patients are being screened for high risk situations? For example, colorectal cancer. You may have 100,000 residents that you're hoping to screen. You can't do 100,000 colonoscopies, but you could do 100,000 at home screening kits and then potentially identify the 5,000 people that are very high risk and have a high need to be brought in for a colonoscopy and have that GI appointment. So certainly our ability to do some risk stratification work, I think is two critical areas where I think we can be impactful. Let's see, what else do we have here? Uh, Lindsay, here's one for you. Just wanted to talk a little bit more about some of your experience with specific rural health populations. Obviously, we don't necessarily want to name names of customers. A lot of that available is actually available online if people have an interest in researching it. But could you maybe just pick one case and kind of talk through the specifics of the program that we run, and what type of results you've seen there?
Sure. Yeah. So we have partnered with multiple public health agencies whose population includes residents in rural locations. In some of the instances, that direct ship to resident workflow was the preferred delivery method as it minimized the need for transportation to receive the test. So, right, overcoming that access to care and kind of the barrier, able to deliver tests and able then to reach members and kind of support them through that activation process, the education of the benefits of testing, through the result delivery process. So definitely something that we've worked with across multiple partners here, and know we'll continue to.
Okay. I see one here that I'll take. I'm surprised it hasn't been asked more times. How do you price your solutions? So a great question. So something that we do at Let's Get Checked that I think is important and really shows what our commitment is and what our level of commitment to our own programs are. We typically price by the test. So if we're deploying a program, we have some targeted communication material, some potential marketing budgets, but really the bulk of the program is saying how much is that test kit? And that is really based on how many people request a kit and actually complete the kit and the process. So I think when I think about rural health transformation programs, there are all different levels of funding that could potentially be available, but something that is actually by the utilization to me, is a very wise area because if the program's not being utilized, you don't want to continue to fund it, and you don't want to have a large amount of money allocated to it, and then see that it's not producing the results that you want. So again, the way that we typically price our programs is actually based on the volume of people that actually take the kit, or the volume of providers that actually say, yes, please send me these types of kits in my office so that I can distribute them. But if the program doesn't see a lot of activity, there isn't a very large bill at the end of the day for any fixed costs. Another thing I think is important to highlight, kind of by the kit pricing or by the visit pricing for telehealth. Again, it includes shipping fees, client management, reporting, the technology, the platform, the phone numbers, the everything. We really try and break that down to say, what's the overall expectation of utilization for a program? And then everything is just by the kit. So again, we don't do a heavy startup fee. We don't want to do additional fees. We don't want to start charging people shipping fees. That is all baked into the prices of our kits. And we actually have the ability to just sell them on a per kit basis. Again, whether that's going out to residents that are in the community, it's really based on the volume of people that are calling in and asking for kits. and asking for various different screenings to be done, or the volume that we're giving out to either provider organizations, FQHCs, community workers, whatever the scenario is, the volume of kits that we're actually deploying for direct handout to patients within the community. And now I do see that we are at 55 after the hour, so I think that is the amount of time that we have allotted for our discussion today. If there are any additional questions, please again continue to send those in to us. And I'm sorry, it looks. Please continue to send those in to us. And again, we'll be sending some additional information with the links to some of the case studies that we've referenced today, some of the research articles that we've referenced, as well as our ebook on Rural Health Transformation Program. Thank you for joining us today.